So I wanted to say thank you so much for having me. I know that this conference has been a few years in the making because of COVID, and I live in Jacksonville, so the hurricane tried to sway me from coming, but made it here, thankfully, safely. I'm very, also thankful to share the stage with some of my colleagues, my mentor, Dr. Havdanerson, my friend, Dr. Shahan, Dr. Ramirez, a colleague and friend. So, it's wonderful that the NET community is very tight-knit in that we want to be accessible for patients, and we're also very tight-knit in that, we as physicians have a common goal, right? It's interesting that the physicians that have been attracted to neuroendocrine, we kind of put aside egos, right? We find common ground in trying to advance the field and try to educate others. And I do love patient education. I love to educate the trainees at Mayo Clinic. So that's a passion of mine. And so I'm thrilled to be able to be here and do that for you all today. So if we'll start, I'm gonna do like a general overview of neuroendocrine carcinoma. We're not gonna go over any graphs or charts or what have you, but I want to be able to kind of leave some time for questions, because I think that interaction and being able to ask questions is the most important part of this whole conference. So, we'll have some concepts to go over, but for the most part, I want to make sure that we get some interaction, okay? So what we're going to do is we're going to review the classification of neuroendocrine carcinoma. So ad nauseum, we go over these classification and the nomenclature. I will say patients and families of those with neuroendocrine type of cancers are usually more well-versed than the general medical community, as in physicians, primary care, oncology, and otherwise. So you should pride yourself on the fact that you are becoming an expert from a patient perspective on these types of cancers. We're also going to go over questions that you can ask your oncologist, or be prepared to ask your oncologist. I always recommend to try to have a list, going into that first meeting with the oncologist, because hopefully the oncologist kind of allows you to kind of drive the conversation, because that's most helpful, because you're getting to address your concerns. And it's important because sometimes you'll forget, I wanted to ask that and I forgot. So have a list, written down of things that you may want to ask. We're going to talk about approach to the workup of the disease, and then a very brief treatment overview. As Dr. Havdanerson mentioned, it's really not a one-size-fits-all. Every patient is treated individually, and the treatment should be tailored appropriately for that patient. I never see two patients back-to-back. Never, but I rarely ever see two patients back-to-back where I recommend the same treatment, right? That's how nuanced and how, detailed this disease is in terms of making recommendations. So as I mentioned, carcinoid, as Bob was mentioning, the founding of this organization, which is fantastic, and the original name having carcinoid in it and having to pivot. So, we don't call these carcinoid tumors. Hopefully the lung folks will catch up one day, no offense, Dr. Ramirez, and stop calling them carcinoid. But in any case, these are neuroendocrine neoplasms. Because if we call them neuroendocrine tumors, it implies that these are well-differentiated, more indolent, usually, tumors, as opposed to a neuroendocrine carcinoma, which is poorly differentiated under the microscope, and it can include terms like small cell, large cell. So you'll hear those things when you're hearing about neuroendocrine carcinoma, but actually, the most common classification of a neuroendocrine carcinoma is neuroendocrine carcinoma not otherwise specified. So it doesn't look like small cell, and it doesn't look like large cell, but it's neuroendocrine carcinoma, okay? So it doesn't have to be small cell or large cell to be a neuroendocrine carcinoma. So this is what a well-differentiated NET looks like. You could see here, there's these nests of cells. They're kind of, what we call rosettes. I'm not a pathologist, by the way, as I should introduce them. I'm a medical oncologist. Dr. Shahan probably mentioned that. And the cells are just more organized, essentially. And then if you look over here, this is just a mess of cells. They're haphazard. They are dividing at a rapid rate. We would need a key 67 to really prove that, but you can take my word for it. So underneath the microscope, you could tell these look like very different tumors. And so, as you would expect, they behave very differently. And I say hug a pathologist because they are critical. They're the first step for me being able to make recommendations for this disease. If I don't get the diagnosis right from the jump, then my treatment is wrong, right? So that's why it's critical, I think, for a neuroendocrine carcinoma to have it reviewed at an academic, tertiary expert center. I just saw a patient the other day, came in, young lady, who appeared to have a colon neuroendocrine carcinoma. Also is diagnosed with an endometrial cancer, they said, incidentally, at the same time. We had the pathology reviewed at Mayo Clinic, and sure enough, it's endometrial cancer as the diagnosis and not neuroendocrine carcinoma. So that pathology is the first step. You have to get it right before you move on to anything else. So this has been mentioned a few times. This is how we determine how aggressive the tumor is beyond looking at it under the microscope. So you have something called the key 67. So I just learned recently, Dr. Shahan had mentioned the podcast. We call it KI 67, or we kind of use a bunch of different names, but it's actually key 67. It was named after a pathologist from Kiel, Germany. So it's key 67 if we wanted to be exact. Not necessary, but you can call it KI 67 all you want. And then the mitotic index, the key 67, see, I was going to say KI 67. The key 67 is automated. So at Mayo Clinic, the pathologists are fortunate in that we have a artificial intelligence algorithm that reads the slide and is able to give us a number that is very exact. So it will tell me 1.88%. So back in the day, they'd have to review multiple levels in terms of fields when they're going through the microscope and count. So they don't have to do that anymore. Now the mitotic index is harder to do because that you actually have to count, okay, underneath the microscope, and you have to see how many cells are in division at that one time when you're looking. And you have to go through multiple fields when you're looking at it to be able to report it. So that's a little bit harder. You'll see more often the key 67 reported. So this is the extent of my PowerPoint skills. And what it shows here is, essentially the neuroendocrine neoplasms being an umbrella, and underneath the umbrella is the classification, right? So here on your right side, it will be well-differentiated neuroendocrine tumors, poorly differentiated neuroendocrine carcinoma, left and right side. So that's really the division. And we just went over kind of how to make that division. By definition, poorly differentiated neuroendocrine carcinoma is grade 3. It's never grade 1, it's never grade 2, it's always grade 3. So, this is what we're talking about is a grade 3 tumor. And like we talked about, there's further division of small cell, large cell, and not otherwise specified. So the neuroendocrine carcinomas I'm going to refer to as extrapulmonary, meaning occurring outside the lung. As Dr. Ramirez mentioned, neuroendocrine carcinomas occurring in the lung is a different disease, right? Usually, almost exclusively, it's due to smoking. Extrapulmonary or neuroendocrine carcinoma outside the lung is not necessarily due to smoking, right? Smoking is a risk factor for cancer, right? Because it causes damage to our DNA. But it's not the main risk factor as it is in the lung. And where do you find these neuroendocrine carcinomas? Well, you can find them pretty much anywhere, but most commonly in the GI tract, usually actually the upper GI tract, esophagus, stomach, And then, the next most common would be colon, rectum. The next most common would be colon, rectum, and then pancreas below that. And like you can see there, skin even, which we call Merkel cell carcinoma. So you can get a neuroendocrine carcinoma of the skin. So what questions do you want to ask your oncologist? So these are the questions you want to go in with and make sure that you get answered, right? One is, where did the tumor start, right? So pretty simplistic, but important in terms of understanding the disease, right? It may not change anything, but it's important to understand so that you can kind of get a handle on what's going on in your body. What stage is the cancer? We talked a little bit, Dr. Havd-Anderson and Dr. Ramirez, about how the cancers are staged, right? They're localized or they've spread to other organs, and at that point they're called metastatic or stage 4. And then what is the key 67 of the tumor? Very important. I see patients often where this is not reported, and it is an important determination and factor in determining what the treatment is going to be. And as I had mentioned, it's important to have your pathology reviewed at an academic medical center. So you may ask, do I need an FDG PET scan? So that's the glucose one, right? That's the one that has glucose, the radioactive glucose that's injected, that we try to identify where tumors are, as opposed to a dotatate PET scan, which is where we try to go after the receptors called somatostatin on the surface of the cancer cell, right? So these are very different PET scans, and the utility of these PET scans is different in different situations. So also, do I need genetic sequencing of my tumor? Should it be of the blood? Should it be of the tissue? And then, are there any clinical trials available? As Dr. Shahan mentioned, the outcomes for neuroendocrine carcinoma are not what we want them to be. The only way that we can move the field forward is clinical trials. That's it. We can't do it any other way. So the workup. So you would initially need imaging. Usually when patients will come see me, they have the imaging already done. So you'll have a CT of the chest, abdomen, and pelvis. I prefer an MRI of the abdomen and pelvis because you get better resolution of the liver and some of the other soft tissue structures in the abdomen. But it doesn't have to be, okay? But if you do get a CT, although the poorly differentiated or the neuroendocrine carcinoma is a little bit different in terms of the need for a dual phase, you still want a dual phase contrast, meaning arterial and venous phase. So make sure you ask for that if you have to. And then this is a little different. I do recommend an MRI of the brain. Neuroendocrine carcinoma, unfortunately, has a higher propensity to spread to the brain. And so it is nice to get that baseline MRI of the brain to rule that out. So I do recommend that. So you want to get blood tests, standard blood count. You want to make sure your liver function is good. You want to make sure your kidney function is good. Tumor markers are, I'm a little ambivalent. Sure, you can check them. They're pretty cheap. But say one is elevated. You might be able to use it moving forward in terms of a surrogate marker of response. So say you started a treatment and the tumor marker was at a certain level. And then you see the marker going down, right? That's always nice. And then if that's mirroring what's going on the scans, absolutely, you could use it. Now, chromogranin A, you always get some hem and haw from the oncologists who treat this disease because of the chromogranin A. It's a bit unreliable, but again, if it's elevated, then you can use it, right? But I don't put too much stock in that number, per se. But I do tell patients it's something tangible, right? It's something that you can monitor and chart over time. And I think it's important to empower patients so that they have something that they feel like they can understand and, monitor themselves. So I don't poo-poo the chromogranin A, but it has its limitations. So genetic testing. So some of the naming that you'll hear sometimes. A somatic mutation is an alteration in your DNA that occurs after conception. So after you're determined to have your 46 chromosomes from mom and dad, things can go haywire in the DNA, right? That's the definition of cancer. Something goes haywire in your DNA that leads to uncontrolled cell growth, okay? Germline, which you'll also hear, is the DNA that you're born with, right? That's unadulterated, just your parents' DNA. Mom's 23 chromosomes, dad's 23 chromosomes, okay? So the testing of tumor cells with the technology we have, you'll hear this term called next generation sequencing. All it means is a fancy way to assess for mutations in the DNA, right? We determine that there is X amount of genes that are associated with cancer. And so we look at those genes in particular to see if they are what we call mutated or altered. And there is evolving data, unlike for a well-differentiated neuroendocrine tumor. The role of genetic testing outside of NEUROENDOCRINE syndrome or something where it's an inherited or germline mutation, in neuroendocrine carcinoma, doing genetic sequencing, I believe, is important for a couple of reasons, one with prognosis and one with treatment choice. Dr. Shahan has done some work on this to identify certain mutations that may predict for response to chemotherapy as opposed to not response. So I think it is important to have your physician do this genetic testing. So this is an example of a liquid biopsy, okay? It's a blood test that we send off to a company, right? And they look for mutations in the DNA that these cancer-causing genes, right? So we hit a home run here. This is a patient with a stage 4 pancreatic neuroendocrine carcinoma, and we found something called a RET fusion. And a RET fusion, we have a drug that blocks this RET. So this is a therapy that the patient may benefit in the future. Now you could also see there's other mutations here. There's something that irrelevant for our discussion, but GNAS and this one. So it's not clear completely that the RET is driving cell growth, but it could have huge implications for the patient. So this is why I advocate for neuroendocrine carcinoma that I think genetic testing is indicated. So is your tumor functional? Most likely not. Carcinoid syndrome, I've never seen it, and I have not seen any publications to show that neuroendocrine carcinoma can have carcinoid syndrome, okay? Maybe some of my colleagues have seen it before, but I've not seen it and I haven't seen it reported. There are rare instances, as Dr. Ramirez had alluded to, where you can see tumors secrete hormone, okay? And these are patients who present with excess cortisol or something called Cushing syndrome or excess calcium, right? If the calcium's really high, then you're suspicious for a hormone being produced. Or if the sodium's really low, you may have a suspicion that too much of a hormone called ADH is being produced. So imaging, this is where it kind of gets a little tricky. As we mentioned, you got to look under the microscope first. That's your first step, okay? And then the imaging really does come in handy. Now doing PET imaging, whether it's glucose or whether it's dotatate or dotatalk, which are the somatostatin receptor imaging, are not going to tell you whether it's a neuroendocrine tumor, i.e. well-differentiated, or a neuroendocrine carcinoma, right? So you do have there is somatostatin expression in neuroendocrine carcinomas, okay, about 50% of the time, right? So as the tumor becomes more aggressive, it typically, or more often, will lose that somatostatin expression because it's becoming less like the cell that it started like, because it's more aggressive and it's dividing more rapidly and losing more of its original identity. So the somatostatin uptake occurs along a spectrum, okay? So this is really a simplistic view of it. So as you get higher in terms of your proliferative rate, it's more likely that the tumor is going to take up the glucose because it needs it, because it's rapidly dividing. All of our cells need glucose, right? That's how we have it. That's how we get energy. That's in contrast to if the cell's slowly growing. It doesn't need glucose as readily. So it won't necessarily light up on the glucose PET, but it will likely light up on the dotatate. As we mentioned, the Octria scan should be retired. Shouldn't be getting those anymore, okay? Especially after the copper 64 dotatate made it a lot easier to be able to do these scans. So this is helpful in determining what scan should I do. So what scan should you do? Should start with a FDG PET, the glucose one. And we'll talk about whether or not you should get the dotatate one and what the implications could be. So here's an example. We've started to classify patients more and more based on this PET imaging. So if a patient has a dotatate negative and an FDG positive, that, what we've seen, is a more aggressive cancer, as you would imagine, with a worse prognosis, okay? Those patients do worse. So there is this push to start doing both PET scans when you see patients with neuroendocrine tumors, particularly the well-differentiated grade 2, okay? But that's outside of the scope of our discussion, and I just wanted to show you some of the differences here when you're seeing, dotatate uptake here, but no glucose uptake. So almost certainly that's a low-grade tumor, as opposed to over here where you don't have dotatate uptake, but look at that glucose uptake. And we call that photopenic. So you see this void right here where there's absolutely no uptake, but then there's an inverse image here of glucose being taken up, okay? So the key here, no pun intended, is the key 67. So there is some data for patients who have a key 67 less than 55%, there may be benefit of PRRT, okay? This is not borne out yet. We need to do clinical trials, but there are some review papers suggesting this, okay? Treatment. So we determine treatment by the stage, okay? And if it's a localized cancer, we like to have the surgeons, like Dr. Liu, cut it out, okay? There are situations where, because these are more aggressive cancers, where we like to do chemo and radiation together before the surgery. And this is typically done when there's a neuroendocrine carcinoma of the pancreas or the rectum, where we like this multimodality treatment. And the reason we do that, again, is because the cancer is aggressive and we want to make sure that we can get as much of it, right, with the surgery in addition to the other therapies, okay? If a patient goes to surgery up front and there's a surprise, right, they take it out and like, oh boy, this is a neuroendocrine carcinoma. There's a question of, well, should we give chemo after? And there is some data, especially in patients with lymph node positive disease. So they take it out and the lymph nodes are positive. That chemotherapy can help prevent it from coming back, okay? So I do consider giving chemotherapy in that setting. So this is my approach, very simplistic. So for a key 67 less than 55%, I typically will use capecitabine and temozolomide or FOLFOXIRI, which is a combination of chemotherapies. Recently, we had a clinical trial that was done, and we were comparing capecitabine and temozolomide versus carboplatin, or platinum, I should say, and etoposide. And the study closed to what we call futility, meaning they weren't going to be able to show that the capecitabine and temozolomide was going to be better than the carboplatin and etoposide. But we think they're pretty equivalent, and you may use one or the other based on the circumstance. But for a key 67 greater than 55%, I typically will use a platinum with etoposide. So what about immunotherapy? We all want to know about immunotherapy because we've seen success, right? And there's some home runs when you use immunotherapy. As Dr. Ramirez mentioned, our experience with immunotherapy has been disappointing. We did a review at Mayo Clinic for the high-grade neuroendocrine cancers and showed that single agent, so if you use one of the immunotherapy drugs, very modest marginal benefit. So there's going to be an ongoing trial. Dr. Shahan's going to talk about it probably in more detail, where we're going to try to add immunotherapy to chemotherapy. Okay, and essentially what we're doing is, remember I had mentioned the platinum and etoposide here, And look, they were going to include patients with a Ki 67 greater than 55%, I believe it says there, yes. And we're going to see if immunotherapy helps. Now, there was more promising studies for two drugs, when you use two drugs that are involved with immunotherapy and unleashing the immune system, one called ipilimumab and one called nivolumab. And there is studies showing there may be a role for these two drugs. There's more studies ongoing. I like to reserve immunotherapy for when my first treatment is not working. I don't typically like to add immunotherapy to the chemotherapy initially. I'd rather study that on that trial. So I do use, not uncommonly, the two drugs. So here's the take-home messages. I recommend a second opinion with a neck specialist. Don't hesitate to ask questions. Don't hesitate to advocate for yourself. Every patient requires a tailored approach to the disease. You and your physician will determine what testing is needed to help better understand the disease: PET scan, genetic testing, liquid biopsy, and then again, seek out clinical trials whenever possible, which is a great segue here to Dr. Shahan coming up here and talking to us about clinical trials. So maybe I'll do a quick introduction for Dr. Shahan. So Dr. Shahan has had a meteoric rise within the field of neuroendocrine cancers. He works tirelessly on clinical trials, writing papers, all to try to advance the field. He's relatively junior, but his body of work would speak otherwise. He's currently at the University of Kentucky, and he leads the theragnostics group there. He's a great colleague. He's always enthusiastic. Patients love talking to him because he's an easygoing guy, very approachable, and I think you all enjoy his primer for clinical trials. Dr. Shahan.
Thank you for that lovely introduction.